psychiatrist, Professor Nechori, Department of Psychiatry from Thalashmi Medical College, and consultant psychiatrist from KMC, and Dr. Arun Kumar sir, consultant and psychiatrist and director of Atma Hospital. Both are well-known persons in Trichy who's practicing psychiatrist. And why this Euro-psychiatric combination? Because we're going to see that. Because many drugs for this premature ejaculation has been an adverse effect of an antipsychotic drug. So it has not been done for a premature ejaculation. So let us see how they're going to handle that. Thank you, sir. Thank you.
Very good afternoon. I started in the morning, saying good morning. Now, very good afternoon, dear friends. Premature ejaculation is related to performance anxiety. I am into performance anxiety now because if I don't perform within time, I will miss the flight from Madurai. So, presenter is with performance anxiety. So, dear friends, Dr. Natesh said regarding, I have my own concept, this is what was told. Actually, I will go into it later. So, first of all, greetings from Yana. You see that, the structure. So, it is the everlasting erection since billions of years. It's a stone. It's standing since billions of years, and that gives me immense power to talk on subject related to sexual dysfunction in men. Now, no disclosures. Let me make it very simple because premature ejaculation in 15 minutes is real premature ejaculation. Talking about premature ejaculation, I mean to say. And premature ejaculation is such a wide subject. Why it is being discussed so much? Because you don't have an answer to it even now, despite the best possible research. Right? That's why it's being here. So, in a simple sense, premature ejaculation is the difference between expectation and reality. This is the expectation and this is the reality. Right? Now, this is in simple language. I will not go into detail. How ejaculation occurs. This is very important to know because we have to target at those points which can be targeted and you get the result. Right? Now, before going further, what was the concept? Let me tell you. Waldinger proposed what is called as IVELT, intravaginal ejaculatory latency time. Right? It was based on penetration. We see that was a time when non-penetrative activities or penetration other than vagina was considered as perversion. Earlier, right? Now, everything is sexual orientation or sexual practices. You cannot call them perversions such as oral sex, anal sex, masturbation, etc. So, is there no latency in these sexual encounters? Definitely it is there. So that's why penetration is not necessary in all. So we said arousal to ejaculation time interval is the latency, or erection to ejaculation time interval is the latency, not IVELT. That was the initial concept, and then I will go later. Now, three constructs are there. One is ejaculatory latency, another is control over ejaculation and relationship issues. Please understand. There is a tool to measure ejaculatory latency. All of you agree, isn't it? You have a tool. Whether you measure it during your clinical practice or not is a different issue. You have a tool. Is there any tool to measure control over ejaculation? There is none. So, what we measured was holding time. Holding time, it is odd. That's what was Dr. Natesh Prabhu was telling. Holding time is the time since the onset of pulsatile penile erection. Pulsatile, please understand. Pulsatile penile erection to time of no return. That's after which you cannot hold. That is holding time. And this was published in Journal of Sexual Medicine earlier. So that is a new concept which I am not going to talk too much because of shortage of time. So these are the three constructs. Now, There are 4 types of sexual premature ejaculation that is described. One is primary or lifelong, who is having shorter latency since birth. So there is nothing to argue or discuss about. Another is secondary or acquired. You have certain conditions such as prostatitis, hypothyroidism, diabetes or BPH or other lower urinary tract symptoms which can lead to shorter ejaculatory latency. That is acquired. So 5% of the people will have. The third is natural variable. You know what is natural variable? Every day is not a Sunday. The person has got certain variation in his latency and he is caught in the vicious circle where he thinks that, oh, tomorrow also I may have the same problem. So ultimately it affects his performance. That's a natural variable, right? That's a maximum you see, 11%. And second highest is subjective. Subjective is the one where person feels that he is having premature ejaculation irrespective of his latency. Even if he is performing sex and is having 10 minutes of latency, he feels that that is short. Right? It is quite difficult, very difficult to treat. Now the question is whether we have to treat all 4 or only those which are scientifically approved such as lifelong or acquired was the question. See, the virtuous cycle, sex positivity helps you to be positive and keep yourself healthy. Right? So, if at all you have to address all 4. Irrespective of the symptom, irrespective of what you find, you have to treat. How to treat is a different issue. You have to treat all 4. And what are to be inquired? So, these are the points, very important, whether it is lifelong or acquired, situational or consistent, association with which type of sexual activity, please note. It can be with one, it may not be with the other. Masturbation, it may be there, it may not be with venovaginal intercourse. People come with masturbation also. I don't know how many of you have seen it, but people may have. And degree of self-reported ejaculatory latency, degree of stimulus required. So what is the amount of stimulation that is required? People come and say, right? Then relationship details. If there is a problem with the partner, then it can affect. So that's why situational consistent is important. Associated distress, that's what is the most crux in the sense, if there is no distress, however short is the latency, you need not treat. So it is a distress, that's the most underlying thing. Then coexisting sexual dysfunction, majority of which are erectile dysfunction, comorbidities and drugs and alcohol. See, this is a big drug list. I can't remember, I don't know if pharmacologists are there or MD Pharmac is there, somebody who is a lecturer or a master in Pharmac, I can remember. I have pasted it in my OPD. I don't remember all this, right? All these drugs can increase the ejaculatory latency, please note. So, whether the person is consuming such a drug, so if the drug is changed, he can come and tell, sir, I was fine till 1 week back, but now I am having difficulty in prolonging the sexual activity. Right? So that's why drugs is important. Now, important to note is psychosocial history, childhood sexual abuse, or sexual practices, or how he is brought up, history of sex education, of course it is non-existent in India. Right? And focus genital examination, very important to look for genitals, perianal area, and neurological testing, vascular testing. Please note, there are beautiful instruments. Instruments means IIF, like instrument, there is premature ejaculation diagnostic tool, PEDT. It's a validated tool. Can you use it in clinical practice? Not possible. It's not possible. You give him a tool, he will read it, he will answer it, and then make it, and then say that, see my dear friend, you don't have premature ejaculation. He will change the doctor. You cannot, diagnose premature ejaculation based on these instruments and then say that I can treat premature ejaculation. Premature ejaculation, as I told in the beginning, it is expectation versus reality. So, in a broader sense, this is an algorithm for treating 4 types of premature ejaculation. Now, what are the therapies? There are psychobehavioral therapies, pharmacological therapies, and emerging therapies. I have divided it into three. So let me be very clear. Psychobehavioral therapies, what they intend to do are, they will either make the patient to understand his condition, that is insight, or they will help to relax, self-relaxation, or distraction is the mode of treatment. See, psychosexual counseling therapy and couple therapy is insight, or to know themselves. Yoga is relaxation, extended foreplay is nothing but distraction. You don't go directly into the performance of sex. Cognitive distraction is clear distraction, and stop, start and stop squeeze technique are nothing but distracting methodologies. Right? So, basis is simple. Three: relaxation, insight and distraction. This is cycle. And whatever that are given in the last there is no clear evidence that they help. Now, pharmacotherapy. Pharmacotherapy, the principle is simple. Any drug that brings down the autonomic drive, that is sympathetic drive, down, will increase the ejaculatory latency. It's a general term. Anything that inhibits the sympathetic drive, right? So, the best one that was used was SSRI, was epoxetine, which is FDA approved, but the best drug is paroxetine instead of epoxetine, and it has to be taken daily. That gives better result than on demand. Non-selective SRIs, the patient is on non-selective SRIs. If it improves, that will help the patient, but it is better to put selective SSRIs than non-selective SRIs. Right? The other one is topical therapy, wherein you are going to numb the penis. So, reduce the neuronal excitation using lidocaine. How do you do it? Ask the patient to apply spray, then that is 20 minutes prior, then let him clean it with wipe it and clear all the lidocaine, that is a prilocaine combination, and then perform sex so that the partner doesn't feel numb. Right? That's a topical therapy. And opioid agonists, PDE5 inhibitors and alpha blockers, unfortunately premature ejaculation. Unfortunately it is. So these things are proved to be beneficial, but the evidence is weak. Right? Now coming to emerging therapies. What are the emerging therapies? Dorsal vinyl nerve cryoablation. You are reducing the hypersensitivity. Right? You are killing the nerve there. Hyaluronic acid gel glands augmentation, so that the under subcutaneous zone you put hyaluronic acid so that the nerve doesn't get stimulated at all, because you have a cover there. Hyaluronic acid gel covers it. Next is circumcision. It is said that circumcision reduces the sensitivity. I don't know how good it is. Botulinum toxin injection to bulbospongiosis so that it is paralyzed. But my question is, if there is a deposition of semen in the posterior urethra, does it help? I am not sure. Right? Pulsed radio frequency neuromodulation. Right? And the last, regarding which I think again Saravoglu is going to talk, that is perineal transcutaneous stimulation. I had gone for the launch of that particular patch. It is called V-patch. You put a patch under the perineum. Whenever they had given me a sample also, I just saw. It's beautiful actually. When you feel like you are ejaculating, you get a shock there. So there is no ejaculation. I told again that it will be used. No. See, what I said is it will be used as a toy. You feel like ejaculation, you get a shock. Stand up again. Right? This is. So Ege is going to talk, and he is going to talk about it, and it is going to be costly in India. I told Ege that unless you reuse, India में क्या है? Reuse तो चाहिए, and you return it, उसके लिए discount चाहिए. नहीं तो कोई लेने वाला नहीं. I I have told him this is a marketing strategy. If they come up with that in India, hope we will have some here.
Sir, I don't think it will be popularly
So I have not yet finished, otherwise premature ejaculation. Let me see. See, so most important thing is we have to make the patients understand and start thinking positively that see, I look at premature ejaculation as a sign that I am hot. If the partner thinks like that, no premature ejaculator will think that he is a premature ejaculator. Right? So, the hope will never be silent, so are we. Thank you very much, and I have finished in time. Thank you.
Excellent presentation, sir.
Thank you, sir.
I have one question. Like most of the PMAs are because of psychological one. And in your experience, what is the common misconceptions that you do encounter when you see patients with PMA?
Sir, the most common, I have told you, most common misconception is simple. Should have been better. This is the only misconception. See, every person, you ask anybody in the audience, okay? Frankly speaking, what do you feel? Everybody thinks that their ejaculator latency is less because that is what is the understanding. That's what you expect, something extraordinary, you don't think it is. That's all. Yeah.
Nice lecture, sir. Just one point I wanted to add was sometimes when you use the start-stop technique, the current generation is more happier to use play-pause. Because you have that pause button, and because many times people say when we stop, it is difficult to reattain the erections. So maybe play-pause, their approach to it. That was one thing I wanted to add, and it was a good talk.
Thank you, sir. Thank you. Thank you. Point well taken. Thank you, sir.
Thank you, sir.
That was just like you, fastest SSRI is dapoxetic.
Yeah.
Next you have psychiatry. Is this the drug from your?
No, it is the drug that is the only drug that is approved, sir. But I use paroxetine. I don't use dapoxetine.
No, dapoxetin is purely used for sexual issues. We don't use it more for depression or anxiety. Although it was marketed as Sir says, we find paroxetine, sometimes even sertraline, which are more easily available, and we are well versed with it. We find them more useful, sir. This concept of on demand, although it sounds good, and in fact there were combinations where dapoxetin and sildenafil, brands like Up and Hold. So those things were marketed, but they are good. But we are more comfortable with the usual SSRIs.
Thank you so much.
Thank you, sir. Thank you very much.
Sir, please felicitate the speaker, sir. Kindly.
It's already done.
Okay,
So,
then you
I have
will
to
felicitate
finish
them.
it, yeah.
Maybe I introduce you now.
Thank you very much.
Thank you, sir.
Thank you.
So we will have a